At the beginning of the pandemic, we always said SARS-CoV-2 is a virus that comes and goes. It does not persist. There is no reservoir. There's a growing body of evidence that is increasingly hard to ignore, suggesting that this may not be the case. We in Link described about 6 months ago the identification of persistent viral proteins in individuals months after they had COVID in collaboration with Ed Getzel looking at exosomes in the plasma. And we've now launched a pretty robust tissue biopsy program with Ma Samsak, Tim Henrich, and others to look for virus in gut tissue. We're also collaborating with David Walt at the Reagan Institute to see if we can measure spike in blood. And I think what I want to convey is that finally, investigator-initiated, network, and nonprofit-funded studies are beginning to start now. I think that this is going to be a national priority for at least the next decade. I hope that we will begin to figure this out sooner than that.
Do we need a new name for this? I find when I say long COVID, people immediately, what brings to mind is you feel crummy 6 months from now, not that I'm at increased risk of diabetes or kidney disease or heart disease. So do you think the name captures this long-term risk of chronic disease yet, or do we need a different way of framing this?
I think there's a lot of back and forth between us and CDC and NIH, and like how do we best name it? And some people gravitate to PASC or post-acute sequelae of SARS-COV-2 or post-COVID condition like the CDC wants to call it. WHO has a everyone has their own sort of a way of. But I think I like the term long COVID. At the time, everybody was telling us that SARS-CoV-2 is an acute infection, especially if you're young and healthy. Previously, you got SARS-CoV-2 infection. You may get sick for a day or 2 or 3 or 4 or a week or 2, and you get over the hump and you fully recover afterwards. Seasonal influenza, and some people with the flu can actually go on to have lingering manifestations, lingering shortness of breath, cough, maybe even fatigue for weeks on end, or even months on end. But the risk was much higher with COVID-19 than seasonal influenza. And number 2, a very important distinction is that the breadth of organ dysfunction, the breadth of organ manifestations is much more extensive in COVID-19 versus seasonal influenza. So right there and then we sort of start thinking that this is really a different kind of post-viral syndrome. Here I attempt to do a deeper dive into cardiovascular manifestations of SARS-CoV-2 infection or of COVID-19 a year after the initial infection. We observed increased risk of a variety of cardiovascular problems, including strokes, dysrhythmias, arrhythmias of the heart, inflammatory heart disorders, ischemic heart disease, and thrombotic disorders. We've also done a bit of work to try to understand whether the metabolic risks after a SARS-CoV-2 infection. There was a lot of talk about the new onset diabetes, so we decided to take a deeper look here in a cohort assembled using 2 major controls followed for at least a year. And a clearly increased risk of diabetes that was evident even among those people who did not need hospitalization for COVID-19, even among those people who did not have a disease that was severe enough to put them in the hospital or severe enough to put them in an ICU. And we've characterized the risk of kidney dysfunction. And if you look at the eGFR trajectories here, or estimated glomerular filtration rate trajectory over the course of a year, people with SARS-CoV-2 infection versus the control group have a much steeper decline of GFR. And that quantitated here is about 2 to 3 milliliter per minute per year. That's really the equivalent of their kidneys aging 2 to 3 years in the span of just one. So you can start thinking about SARS-CoV-2 infection as almost as an accelerant of aging, as a sort of it ages you in the span of 1 year. These kidneys age 2 to 3 years in the span of just one. And this is really remarkable. Now, luckily here, if you really see that much of the decline in eGFR trajectory happened in the first 200 days, and the ensuing days is sort of kind of plateau. So we're hoping when we do our 2-year studies that really the risk plateaus over time, that really the hit is really initial, and in the first 6 months or so, that is this decline, that is this accelerated aging, and it sort of peters out and plateaus afterwards. This is what's looking like here, but this is really pending confirmation of a longer term study. So this is really one slide to sort of, show us, do vaccinations work? Do vaccinations, well, I told you about long COVID. You're probably in your brains like, okay, well, I'm vaccinated and maybe boosted. Good. We want that. That's wonderful. Absolutely wonderful. How much, what's the effect of vaccination on long COVID? And And our different studies have different results. And in our work and our data, we see risk reduction, but not much. So vaccines reduce, but do not completely eliminate, actually minimally reduce, but overall by only 15% in the study, but do not eliminate the risk of long COVID. The risk reduction is variable according to organ system. Most of risk reduction happens in the pulmonary space, in the pulmonary organs, and also in coagulated clotting disorders. So what are the implications for health systems? We think that the burden of long COVID in the US is around 4 to 7%. That's really on the lower end of the estimate spectrum, but those are our studies, and this is what we sort of think is anywhere between 4 and 7% in the US. So we think long COVID can also affect multiple organ systems and may result in rise in the burden of chronic diseases, specifically cardiovascular disease, diabetes, kidney disease, and maybe neurologic disorders. Best way to prevent long COVID is to prevent COVID in the first place. So you haven't gotten infected, you haven't had a primary infection. I think, doing your best to try to prevent that infection is really the best thing you can do for yourself, or preventing reinfection. I cannot also give this talk without also talking about misinformation, disinformation, and gaslighting. We have a role as a medical community to actively combat misinformation, disinformation, and gaslighting. Actually, some of it is medical gaslighting. We worry a lot about long COVID in kids, leading to development and educational attainment problems. Long COVID will likely affect or put a dent in life expectancy, which is really going in the wrong direction now in the US, and it's really a tragedy on its own. We have significant economic implications. The early indications now that we're getting from the Census Bureau, from think tanks, and then are really substantial effects on the economy and the labor market, and that cannot really be ignored. And we think we certainly have societal implications.
You hear a lot of people who say, I've been trying to dodge this for 2 years, and I finally got it, and I felt crummy, but then I felt relieved because at least I get it out of the way. And what I tell them, will tell me if I'm right, is I wish that were true, but your second case adds to your risk both of symptomatic long COVID and maybe, Ziyad, I don't know, your risk of long-term outcomes. So maybe either Michael or Lekshmi, sort of let's start with the symptomatic point. Your chance of having symptoms several months out, how has that changed for your second or your third infection versus your first?
Yeah, I mean, there are so many different factors, and we're kind of in the 6th or 7th era of COVID now. So layering on different variant-specific risks, vaccines, multiple boosters. So I think it's really hard to compare apples to apples. I think the point that's important that I think you made is I'm still trying to avoid getting COVID because that is the best way that you could avoid getting long COVID is to either not get COVID or have fewer COVID infections, presumably.
And then if you had COVID before, other than the immunologic effect of whatever protection that grants you, do you feel like your risk of long COVID is any different for your second infection than it would have been for your first, based on what we know?
I'd be curious what Ziyad has to say. I mean, I can say we've started now in our cohort to see people who we knew after their first COVID infection who are now getting a second or third. And so I don't have answers to that yet. But it's definitely something that we're looking into.
Anecdotally, do they get worse? Does their long COVID get worse after their?
Some people I know did not have long COVID after a first infection and subsequently got it. Other people I know did have it after a first infection, got reinfected, were really worried about it, and their symptoms did not get any worse, or in some cases, maybe even improved. So it's really hard to tell.
Got it. Ziyad, any comments on that?
We studied the risk of reinfection. That was in a preprint now, and fortunately has been accepted in one of the journals that will be coming out in mid-November. The second infection really matters. So for people who really have a first infection, if they're asking the question, does protecting myself from a second infection really reduce my risk of long-term problems? And the answer, in our view, in our data, absolutely yes. So it really matters to protect yourself from a second infection. And the reason is because we started seeing patients in the clinic with this air of invincibility about them that, oh, hey, doc, I'm vaccinated, I'm boosted, and I had infection. So I had both vaccine-derived immunity and natural immunity from infection. So they had like this invincibility about them that, oh, if I get the virus a second time, like I've had it one time, so I have this immunity, I'm vaccinated. And it may actually make it milder in the acute phase, but absolutely the risk is additive. It certainly adds or contributes additional risks in the second and third infection. So
there was a lot of hope, just like there was hope when vaccines rolled out, that it would totally eliminate long COVID and everybody would just get treated up front. They wouldn't get long COVID, done. As part of that case series that we published, we actually had one individual who took Paxlovid according to the EUA and subsequently developed long COVID. And so I do not think that it will totally eliminate the risk, but it makes sense that if the amount of virus that people have early on matters, that it could potentially decrease the risk. This is one of the questions that we're hoping to investigate now with Link and in collaboration with some of the other groups at UCSF.
It sounds like it's fair to say at this moment, the hope that taking Paxlovid early, that one of it, it's proven benefit in terms of lowering mortality and hospitalization rate, but the hope for benefit that it would lower the long COVID risk, that has not been proven.
Not proven, but probably won't increase the long COVID risk. So
the viable hypothesis to be tested. The viable hypothesis to be tested, though, right? It's not proven, but we don't know.
The thing that I worry about is what Ziyad just said, which is that I do Paxlovid prescribing for people with acute COVID as part of telemedicine at San Francisco General. And some people tell me that they don't want to take it because they're concerned that they're going to get rebound and get long COVID. And so the worry that I have is that, again, speaking to what Ziyad said, is that there's a lot of misinformation or disinformation going around, and it makes it really tough for people to make informed decisions without the guidance of their provider.
Yeah. Well, it's misinformation, disinformation, and an anecdote. I tell you, my wife took Paxlovid, got rebound, and has a fairly soft version of long COVID, still has pretty profound fatigue 6 months out. And that fatigue symptom came really during the rebound phase, not the initial phase. So, I watch that, it makes me wonder. I have no evidence beyond that, but, it's natural to wonder about it. But at this point, sort of an open question. Lekshmi, how do you have these patients in some ways, some of them have disabling symptoms and they're desperate to try something. And you said that all we know to do is give them symptom relieving therapies. I imagine there must be an inclination to just do some Hail Marys and try some stuff, right?
I think I completely understand that desire while we're in this place of a lot of uncertainty and not good therapeutic options. I think, like Dr. Peluso said, I have a number of patients in our clinic who've had a second COVID infection, who've taken Paxlovid, and we see the heterogeneity there. Some have gotten better with it. Some got better temporarily and then kind of returned to their poor baseline. Some got with no difference at all in symptoms. And it goes back to that car analogy, right? When you think about what is the underlying biology, if your steering wheel is broken and you're giving it extra brake fluid, it's not going to help. So we really need to target the biology to help the phenotypes, to help the symptoms. And it really needs to go in that order, because otherwise we're just kind of throwing things against the wall and we don't really know exactly what we're treating or how. But I completely understand the desperation of patients and families who want anything to get better. And there's so much uncertainty, and months of living with such a poor quality of life, being unable to work, is devastating for people.
Yeah. Maybe the last question, Ziyad. I have to say your research has profoundly impacted the way I think about this, and because I really do think about trying to avoid COVID, both because of symptomatic persistent symptoms, but also these long-term risks of things that I just don't. I'm old enough to be at risk for a heart attack or a stroke or a clot or kidney disease, and the idea of elevating my risk to the level that you're describing is scary. I don't know that your research has sort of gotten through the public consciousness in a way that I would have guessed if you talk about the magnitude of these risk factors for some of the most scary, non-communicable diseases. First of all, do you think that's true? And maybe in addition, I think maybe one of the reasons is people look at the research and wonder if it's real. Like, are there confounders here? Does someone have COVID? Are they plugged into the medical system so we just find their MI earlier, or something else that explains it as opposed to being real? So first of all, answer the sort of epi-confounding question, and then maybe you can end with, are people paying enough attention to this?
So, these are by nature sort of observational work. So this is not a randomized experiment. And the tragedy here is that we will never be able to randomize people to COVID versus no COVID. That would not be ethical. So I think that the best we could do is try to do, really apply the most rigorous, causal inference approaches to try to elevate our confidence that what we're seeing is really a true cause and effect, not really due to confounding. And our experience sort of doing a lot of negative controls and applying as much scrutiny as we can, and also reproducibility by other groups, both in the US and in Europe and elsewhere, sort of elevates the confidence that this is really there. So why has it not really? I don't know, maybe I live in a little bit of a bubble, but in my bubble there is a lot of recognition about this.